She had diffuse ST segment elevation in multiple leads. I was so expecting a perfectly normal EKG, so I rechecked my lead placement to make sure I hadn't somehow created a STEMI-looking EKG by mixing the leads up. And in fact, I had done the EKG correctly. So I asked, have you ever had any problems with your heart, or do heart problems run in your family? She said, no. So I excused myself so I could go show the EKG to the physician. I approached the doctor with the EKG in hand saying, am I seeing what I think I'm seeing? This is the EKG from a 20-year-old. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response Run podcast. Today we're going to be talking about a not-so-common diagnosis, pericarditis. We will cover how it presents, the diagnostic criteria, some common, more dangerous diagnoses that you don't want to falsely assume are pericarditis, and the nurse's role in recognizing and treating pericarditis. So, let's first dive into a case. I was working nights in the ER as a new-ish grad and brought a young woman in her 20s from the waiting room back to my room. She was complaining of chest pain. Now, as an ER nurse, I think the most common chief complaints that we see are chest pain, abdominal pain, headache, and shortness of breath. So needless to say, we see a lot of chest pain. And the bulk of it is not from a myocardial infarction, but we pretty much assume all chest pain is from acute coronary syndrome until proven otherwise. So I bring this woman back and I started placing the leads on to get a 12-lead EKG while I was getting the story from her. So she'd been sick for a few weeks prior with an upper respiratory infection and had gotten better, but her chest pain had gotten progressively worse over the past few days. I asked all the typical PQRST pain assessment questions, but I usually go backwards. It just makes more sense in my mind. That way it feels more conversational and less robotic, in my opinion. In case you don't remember the PQRST acronym from nursing school, P is what provokes or palliates the pain. Q is what is the quality of the pain, like describe it. R is for region or radiation, like where is the pain. S is for severity, so how bad is it? You can use the pain scale if you'd like. And then T is for time, like when did it start and how long does it last? So in reverse order, I asked her, time, when did it start? She said a few days ago, but got really bad tonight. Severity. I asked her to rate it on a scale from 0 to 10, and she said sometimes it's a 10, sometimes it's a 3 or 4, but it's definitely painful enough to keep her from sleeping. Region. I asked, where does it hurt the most? Can you point to it? And does the pain radiate to anywhere? She responded and pointed towards the center of her chest and into her shoulder neck area. And I pointed to her left center chest and then to her trapezius and shoulder, and she confirmed, yes, that's where it hurts the most. Quality. So I asked her to describe the pain. Was it sharp, dull, throbbing, aching, stabbing, pressure? And she said, all of the above. And then I asked the most valuable question that should have clued me in that this was pericarditis, but it didn't because I was new and I didn't know as much as I know now. So I asked her, like I ask every patient, does anything make the pain feel better or worse? And she said, I absolutely cannot lay down. I have to sit up. Laying down is excruciating. So by that time, I had captured the EKG and she had diffuse ST segment elevation in multiple leads. I was so expecting a perfectly normal EKG. So I rechecked my lead placement to make sure I hadn't somehow created a STEMI-looking EKG by mixing the leads up. And in fact, I had done the EKG correctly. So I asked, have you ever had any problems with your heart, or do heart problems run in your family? She said, no. So I excused myself so I could go show the EKG to the physician. I approached the doctor with the EKG in hand saying, am I seeing what I think I'm seeing? This is the EKG from a 20-year-old. She looked at it and quickly said, it's probably pericarditis, but let's go assess the patient because anything's possible. So I returned to the room with the doctor, and I started an IV and drew blood while she auscultated the patient's chest. I knew she was looking for a pericardial friction rub. I got that answer right on the test in nursing school, and I knew it was associated with pericarditis, but I never actually heard it on a real patient at that point. Unfortunately, there was no rub to hear on this patient, or not at least at the time that I or the physician listened. We drew troponins, they came back negative. Chest x-ray, negative. Chest CT, for good measure, negative. And did another EKG 3 hours later just to make sure things weren't changing. We ruled out all of the deadly diagnoses associated with chest pain. It's not a pneumothorax. It's not a pulmonary embolism. It's not a dissecting aortic aneurysm. It's not acute coronary syndrome. So all signs were pointing towards pericarditis. And she met the diagnostic criteria. So we gave her some ibuprofen and sent her on her way with taper instructions for taking ibuprofen and a script for colchicine. I learned so much from caring for that patient and all of the research that I did after the fact. I swear, the only fact that I learned about pericarditis in nursing school was that it produced a pericardial friction rub, and that was the extent of my knowledge at the time. But this patient did not have a rub and scared the crap out of me when I saw her ST segments on her EKG. So let me share what I have learned since that night, starting with the basics. By definition, pericarditis is inflammation of the pericardium, which is the thin, double-walled sac that surrounds the heart. So not myocarditis, that's when the heart muscle itself is inflamed, just the pericardial sac surrounding the heart. The pericardium consists of two layers, the visceral layer, which is attached directly to the heart, and the parietal layer, which forms the outer sac. And between these layers, there's a small amount of fluid that's like lubricating the two. But when you hear that there's a pericardial friction rub, it's those two layers rubbing against each other. However, you only hear the rub at about 30% of the time. In pericarditis, inflammation of the pericardium leads to an influx of inflammatory cells, so increased vascular permeability and the release of inflammatory mediators like prostaglandins and cytokines, and that process can result in the accumulation of excessive fluid in that pericardial cavity, known as a pericardial effusion. The inflammation can also cause fibrin to be deposited in there, and that leads to thickening and scarring of the pericardium, which could potentially result in constrictive pericarditis. This chronic condition restricts the heart's normal movement, which impacts its function and could lead to heart failure. But that's like worst case scenario. Point is, pericarditis is not a heart attack. They are very different. They present different. As far as the cause of pericarditis, well, that's the tough part. Pericarditis can have numerous etiologies, but they all boil down into one of two categories, infectious and non-infectious. So viral infections are the most common cause. Viruses like Coxsackie virus, echovirus, adenovirus are the most common culprits. My patient had a virus a couple weeks ago, thought she was getting better, and then her chest pain started. There's also bacterial pericarditis, though it's less common. It can occur, particularly in cases of tuberculosis or in post-cardiac surgery infections. Even fungal and parasitic infections are possible. They're rare, but they're more likely in immunocompromised patients. Then there's non-infectious causes like autoimmune conditions, so lupus, rheumatoid arthritis, where the immune system mistakenly attacks the pericardium. Pericarditis can also result from trauma, like blunt chest trauma, or from medical procedures like cardiac surgery, and metabolic disorders like uremia, particularly in chronic kidney disease, can also cause pericarditis. Certain medications like procainamide and hydralazine have also been associated with drug-induced pericarditis. And then lastly, pericarditis can develop following a myocardial infarction. That's known as Dressler syndrome. And this is due to an autoimmune response that's triggered by the heart muscle injury. So you don't want to miss that zebra and accidentally diagnose it as just pericarditis and miss the underlying myocardial infarction that caused it. More on that in a minute. Okay, so we talked about pericarditis and what causes it, but how can we diagnose it? Well, the diagnostic criteria are pretty simple. You can diagnose pericarditis if the patient has 2 or more of the diagnostic criteria. So number 1 is that classic pericarditis chest pain history. The patient says it's sharp, it's pleuritic, it's positional, it radiates to the trapezius. All of those things are like the classic chest pain. Number 2, a pericardial friction rub. That's, for the most part, pretty indicative of pericarditis. But again, it's not always there. Number 3, pericardial effusions on echo. And number 4, characteristic EKG findings. So my patient only had 2 of the 4. She did have the sharp positional chest pain that felt worse laying down and better when she sat up and leaned forward. And she also had diffuse ST segment changes. But no rub, at least when I listened, and I listened good, and no effusion. So I wanted to break down each of these a little more, but I wanted to make one very important point before I do. So if you are multitasking right now, come back to me to catch this point. All right, here it is. Pericarditis is a diagnosis of exclusion, meaning you have to exclude all of the other big killers that cause chest pain before you can make this diagnosis. It would be easy just to say, chest pain, check. Diffuse ST segment changes, check. And then label it as pericarditis and miss a STEMI or a PE. Not every patient is textbook. So rule out all the big stuff first. And then, and only then, can you call it pericarditis. Okay, you can go back to multitasking now. So as far as each of those criteria, let's start with chest pain. Pericarditis chest pain tends to be pleuritic, meaning it may get worse with coughing, sneezing, deep breathing, certain position changes. Not always, but the classic pericarditis chest pain is reported by the patient that it hurts worse to lay flat and feels better when they sit up and lean forward. The patient might say, I can't sleep because I have to sit up. Sitting forward can reduce the pressure on the parietal pericardium, especially during inspiration. Patients may also report the chest pain radiates to the trapezius ridge. Interestingly, chest pain is likely to be present with infective pericarditis, but may be minimal or absent in patients with pericarditis associated with rheumatologic disorders and uremic pericarditis. So summary, chest pain is tricky. It's not always textbook, and every patient's experience with chest pain may be described a little differently. So you don't want to wait for them to say, my chest pain feels pleuritic, or it feels sharp and stabbing. Everyone experiences it very differently. So that's why you need 2 or more criteria to diagnose pericarditis. The next diagnostic criteria of pericarditis is that classic pericardial friction rub. And the pathophys is in the title. The sound you hear is literally the friction between the sliding of the inflamed visceral pericardium against the parietal pericardium or the parietal pericardium rubbing against the pleura. It can be difficult to hear, especially in a noisy room. Hey guys, I'll get back to the episode in just a second, but I wanted to pause to let you know that if you love my podcast but wish there were more of these awesome episodes, well, I have great news for you. There is more. My Rapid Response Academy is basically podcast 2.0, plus the huge added bonus of community. I love hosting this podcast, but it's just me, recording into a microphone often by myself. And this extroverted gal who loves to both teach and mentor nurses just wanted more. So in the community I created, I get to teach live every Friday and break down topics that I think every nurse needs to know. From deep dives into the pathophys of every emergency you can think of, to some of the heart of nursing topics as well, like how to advocate with confidence for your patient, how to de-escalate situations, how to deal with bullies on the unit, how to be an amazing preceptor and charge nurse, and some of the mindsets and boundaries that have helped me stay in nursing for the last 20 years, not burn out, and thrive at the bedside. I love the opportunity to answer your questions live, and it's such a joy to see nurses supporting each other in this community. So if you're an acute care nurse that wants to expedite your growth as a nurse and invest in yourself so that you can provide the best care to your patients, you would love my Rapid Response Academy. So to learn more, I put a link in the show notes for you. Hope to see you there. Friction rubs are best heard at the left sternal border around the third intercostal space. Some of the things you can do to optimize your ability to auscultate a rub is to sit the patient up and lean a little forward and have them hold their breath, ideally at the end of forced expiration. So, and then listen. I've heard the sound described as sandpaper rubbing together, but I think that might be a little harsher than the actual sound. So when I worked in the cardiac ICU, I heard pericardial friction rubs a lot more often than when I was in the ED. A lot of inflammation can occur when you cut the chest open, and a pericardial friction rub was not that uncommon or alarming in that patient population. So to me, it sounds like if you take your hair and rub it between your fingers, that's a rub. Let me see if I can mimic it in the mic. But here's the thing. If you hear a rub, that can be very specific for pericarditis. But if you don't hear a rub, they could still have pericarditis. And they could have a rub 1 minute and it go away with position change. It's very unpredictable. So another reason why you can't rely on a pericardial friction rub to make your diagnosis. So it's worth listening for, yes, but it's only one of the 4 diagnostic criteria. And remember, 2 are needed to make the diagnosis of pericarditis. The next is a pericardial effusion. So that is where fluid, like more than the normal amount needed for lubrication, builds up between the layers of the pericardium. Remember, this is an inflammatory process, hence the itis at the end of pericarditis. With inflammation often comes increased vascular permeability, and this can result in an accumulation of excessive fluid in the pericardial cavity, known as a pericardial effusion. These are usually small and don't even require intervention, but sometimes they're big enough to be drained. The presence of a pericardial effusion may or may not affect your ability to hear the pericardial friction rub. Pericardial effusions are diagnosed with an echocardiogram or even at the bedside with point-of-care ultrasound. And the final criteria is EKG changes. So, first thing to note is that there may be diffuse ST segment changes, meaning you might see an elevated ST segment in multiple leads, like all of them. But here's the thing. When someone's having a myocardial infarction, it would be highly unlikely and really bad luck for them to have an occlusion in all of their coronaries, resulting in ST segment elevation across all the leads. Usually, you'll just see ST segment changes in the leads that reflect a particular vessel or a particular portion of the heart. For example, elevation in leads 2, 3, and AVF usually reflects an inferior wall MI, but elevation in leads V3 and V4 is from an anterior MI. My patient had elevation in almost all the leads, and that's because the whole heart is inflamed, not because of an occlusion in all the vessels, but it definitely scared me. Additionally, the shape or morphology of the ST elevation in pericarditis is a little different than the morphology of elevation in a myocardial infarction. So if you look closely at that elevated ST segment, you'll notice that it either scoops into a convex or a concave shape ending at the T wave. You might have heard ST segment elevation referred to as, quote, tombstones, because the ST segment looks like a big hump or a tombstone. That is a convex shape. Another way to remember that is that convex ST segment morphology looks like a frown face, like the hump of a frown, right? The 2-point facing down. So a way to remember that is you would be frowning if you were having an MI. On the flip side, ST segments of those with pericarditis often have a more concave shape, meaning they dip down and slope up before reaching the T wave, kind of like a smiley face. So if you had chest pain and found out it was just pericarditis and not a heart attack, you would be smiling. Okay, that's how I remember it. Now, this is not 100% of the time, but according to a study done in 2001 by Brady et al., looking at the morphology, frowny faces versus smiley faces, those had a 94% predictive value of myocardial infarction versus other sources of ST segment elevation. So that's pretty darn valuable, pretty darn close, right? 94%. Another thing to look at is if you have elevation in leads 2 and 3, compare which one is worse. Because the normal repolarization of the heart will occur at lead 2 before lead 3, ST elevation at lead 2 should be bigger than lead 3. But in a myocardial infarction, specifically an inferior wall MI, if you have ischemia, you're probably going to see the opposite, meaning lead 3 ST site elevations will be more pronounced than in lead 2. So just to review, when you look at the EKG, if lead 2 is bigger than lead 3, it's probably pericarditis. But if lead 3 is bigger than the lead 2, it could be a myocardial infarction. This is not 100%, but it's something to note. And then there's also this thing called Spodek's sign, which is the downsloping of the TP segment. So after the end of the T, that point is higher than the start of the next P wave. So it's almost like it's sloping down, but this is only present about 30% of the time. So again, all these criteria are not 100%, but they are worth noting. There's actually a ton more, but I think I would lose you if I start listing all of the multiple options for how pericarditis presents, because there are so many variations. But the only thing I did want to mention is that depending on where in the course of their disease process they present, the EKG can look very different as the inflammatory response mounts and then resolves after days, weeks, and months. So there are 4 stages. Stage 1 occurs over hours to days. It's characterized by diffuse ST elevations, meaning like all over the board. The morphology tends to be that concave shape. You may see ST depression and AVR in V1. You should not see any reciprocal ST depressions. That often is from a STEMI. You might have PR segment depression, and then there's that whole Spodek sign, the downsloping of the TP segment. All right, then there's stage 2. So that's when the ST and the PR segment starts to normalize again. The T waves kind of flatten out and then transition to deep symmetrical T wave inversions. Then there's stage 3. That's when things are starting to resolve. So the ST and the PR segment has resolved. And the T wave inversions may persist a little bit. Stage 4 is complete return back to the baseline EKG morphology. So like I said, there are no 100% definitive signs of pericarditis on the EKG. You can have diffuse ST segment changes in a wraparound LAD occlusion. Patients can have Spodek sign during a heart attack. And the whole smiley face versus frowny face, concave versus convex EKG morphology isn't predictive 100% of the time. But if you put all the pieces together and you look at your patient and listen to their history, listen to their heart, review their labs, and maybe look at their heart with an ultrasound, that can help you make the best diagnostic and treatment decisions. You don't want to send a patient having a heart attack home with a script for NSAIDs. So to review, you need to have 2 of the 4 diagnostic criteria to call it pericarditis. And that's only after you've excluded all of the other really bad stuff. Those criteria are pleuritic chest pain that's worse laying down than sitting up, diffuse ST segment changes, pericardial effusion, and pericardial friction rub. The last thing to discuss is the treatment. And really, it's pretty simple. Non-steroidal anti-inflammatory medications like ibuprofen or aspirin, you would usually taper it. So like 600 milligrams Q8 hours for 10 days, and then taper to 400 milligrams for 10 days, and then 200 milligrams for 10 days. Also, colchicine is recommended to reduce inflammation and prevent chronic recurrent pericarditis. That's the big thing you don't want to happen in these patients. So patients will go home on colchicine for like 3 months or more. And finally, a PPI or proton pump inhibitor, because NSAIDs and colchicine are pretty rough on the stomach lining. So we're not giving the PPI to fix the pericarditis. We're giving it because of the medications we have to give for the pericarditis. All right. In rare cases where the pericarditis is from bacteria, antibiotics may be needed and possibly an admission to the hospital. Sometimes it's so severe that a pericardiocentesis is required, and maybe even a pericardial window if the patient's pericarditis is restrictive and affecting cardiac function. But the majority of the cases, patients can go home on PO meds. So there you have it. Those are all the things I have learned since my first encounter with a scary-looking EKG with diffuse ST segment changes that turned out to be pericarditis. If you remember anything from this episode, may it be that pericarditis is a diagnosis of exclusion. So make sure that you have effectively ruled out all of the killer diagnoses before sending a patient with pericarditis-like symptoms home. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.